also want to recognize and acknowledge our key sponsor, the Running Room. We are grateful for their patronage and participation in helping us to provide all of these wonderful opportunities to learn and grow and develop our knowledge of what is happening in healthcare these days. So thank you both to Diabetes Canada and the Running Room. And also thank you very much to our guests today. Welcome.
Thank you. Thank you for having us.
So I'd love to begin with our first question. And as you both know, our questions came from our audience who's watching today. And so these are key things that people are very interested in getting answers to. Some of them are very big questions. We received some very specific questions as well. But Dr. Shepherd, if we can begin with you and this first question, which is really about sort of framing, if you will, the relationship between mental health and chronic health conditions.
Yeah, absolutely. And I think that, you know, as you've mentioned, that this is a question that's coming from the audience. This is something that's of major concern and relevance to people, and something that's really commonly experienced. So I think that we can certainly start by speaking to that it is a very common experience for individuals living with chronic disease to be coping with mental health and psychological distress going along with that. And the relationship is straightforward and complicated at the same time. So we know that people who live with chronic conditions are at increased risk of being diagnosed with something like depression or anxiety. And vice versa, we know that individuals that live with, you know, chronic mental health conditions like depression are also at increased risk of developing some chronic conditions like diabetes, for example. But beyond that, it does get a little bit more complicated, and what we're sort of learning more about and recognizing is that when some individuals present with symptoms of depression or anxiety, or it looks like depression and anxiety, they're actually expressing psychological distress that's associated with living with their chronic disease specifically, and not necessarily a diagnosable mental health condition. So we call this disease-based distress, and it's really a psychological distress that, you know, manifests as a result of living with and coping with the emotional burden and the challenges associated with managing a chronic condition on a daily basis.
So why, Dr. Vallis, does this often sort of get misunderstood or mislabeled, if you will?
Yeah, so it's actually a great question. And I would say that the main reason is because we don't actually have a fulsome language to describe our experiences. So in the medical system, doctors are trained to diagnose, be on the lookout for mental disorders, depression, anxiety, psychosis, bipolar illness, personality disorders. And so from a medical point of view, we screen for these. And so the problem is that nobody wants to be sick. And so it's different being in a major depressive disorder, which means that you have a primary depression problem, is very important to address. The challenge is, if you're struggling with diabetes or heart disease, you don't want additional problems, and you actually don't really meet those criteria. So we have been working to try to change the language. So in Canada, for instance, we have clinical practice guidelines, and Diabetes Canada releases these guidelines, and we've now expanded. About 10 years ago, we changed our recommendations to go from screening for depression or anxiety to screening for distress. And I think that's actually really important to make the distinction. And for the audience, the best way to do this would be to just sort of respond to the following question. If you're experiencing distress, and I were to ask you, if you did not have this medical disease, would you be telling me your experience? It's a very simple question, but it all very quickly, people in the audience will be able to see, no, my distress is because I can't walk any longer because my knees are gone. I worry about going low during the night. Nobody in my family really understands my illness. And so those would be people who, if they didn't have the disease, they wouldn't be telling. That's what we call disease-based distress. And so people like Tiffany and I are really trying to support the medical and mental health community into just expanding our language so that we can include disorders, but importantly, address this notion of disease distress.
So how difficult is that conversation with your medical colleagues? Is this something that's relatively new in discussion? The language is new because the term distress is, I've never heard before, but maybe there's a little bit of history that I'm not aware of or the audience is not aware of. And how is that being received by your medical colleagues when you have these co-diagnoses, if you will?
Great question. So when you present, it's a very easy sell. So it's a language that makes sense. And so when Tiffany talks about disease distress, we just think about four things. What's the emotional burden? How heavy is this disease for you? What about managing your disease? How much does taking care of your disease interfere with your life? How about the support of people in your life? Do you feel like, people are on your side, or do you find that it's hard to become understood, or you feel stigmatized? And then do you feel tension in your relationship with your providers? Because we call this patient-provider distress, which is also important. And so what we find is that the medical community is really receptive, but we're struggling with resources. And so the medical providers right now often say, I get it, makes perfect sense, but I don't have time. And then trying to develop the resources. So these become the issues that we're really looking to promote. And by the way, we believe that a big part of the solution to this is patient engagement. In other words, when individuals living with disease start asking for appropriate mental health help, then the doctors are obligated to address those issues. So we actually believe that it's the partnership between providers and individuals with lived experience that will be part of the solution.
So we have just opened up what might be proverbially called the big Pandora's box of this conversation. There is so much to unpack in that. So I want to move to our next question to really start to dig into some of these things that we talked about at that 100,000-foot level. So Tiffany, we're talking about some people who feel shame of being a burden. I can put my hand up in this particular case because I have a chronic disease called arthritis, and mine's pretty serious. And so it often becomes, can you come and help me do this? And my children don't live close by. So it's a lot of work and energy and effort. And this is fundamentally an invisible illness, especially when I've had my cortisone shot to help with the pain. But how do we normalize this distress? What can we do? What are some things that are if there is such a thing as something simple to normalize this distress?
And I think certainly talking about it is the first step, and hearing about this sense of feeling like a burden and this sort of shame that goes along with that, and feeling held back internally from being able to ask for help or holding ourselves back from seeking support is really, really common. I hear this so much, that people don't want to be a burden to their friends and family members, and they worry that they don't want to be talking as if they're like maybe the perpetual patient, or that all they're ever talking about is their disease, and they feel like the people in their lives have enough going on that they don't want to burden them with that. And so this is something that to normalize, in the sense that it is something that we hear across chronic diseases so commonly, that people really struggle with this experience. And as you pointed out, especially with those invisible illnesses that are more difficult for other people can't always observe your pain, observe your fatigue, observe when your mind is really cloudy, and those kinds of things. So yeah, absolutely, it is a challenge for sure, but something that's really, really common.
So Michael, what do we do in order to be able? I heard some sort of inklings of things that Tiffany was saying about it's okay to ask for help. I'm a proud, stubborn person. I don't like asking for help, but what does that do, and what surprises happen for people when they start to feel less of this burden?
Yeah, yeah. I think it's a great question, and for me, I think, and why these kinds of events are actually so important. It's really about trying to bring this to a public level. And so I have experience, in several chronic diseases, one of them being diabetes. And we did a 17 country survey of individuals living with diabetes and family members, and 17,000 participants, so a lot of people. And what was really interesting, because what we found was that 53% of people with type 1 diabetes and 48% of people with type 2 diabetes experienced intense distress at times in their lives. So all of a sudden, it's like not the occasional person. So I think that when Tiffany sort of kind of says it's okay to talk about it, it's like it's okay to not be okay. Because remember, in Canada, by the time you're 50, you've got at least one diagnosis and one medication. By the time you're 60, you've got at least two diagnoses and two medications. By the time you're 70, you've got three diagnoses and three medications. I'm sorry, I'm not trying to be funny. This, in fact, is true. The base rates of chronic disease as we age really go along. So I think it's really, it's okay to not be okay. And I think in an era of equity, diversity, inclusiveness, we have to just sort of embrace that, you know what? Well, maybe I'll just sort of end it with the following. I've asked thousands of people in the last decade, when I've been in front of individuals, how many of you disagree with the following statement? And just before I tell you what the statement is, no one has ever disagreed with the statement. Isn't that interesting? Literally thousands. So punchline, what was the question? Do you agree life is hard? Everybody says, yep. And so I think what we're talking about really is to normalize distress, is just to acknowledge. The depth of a friendship is measured in the support that's there when the person has help. The quality of a relationship is not measured by how good it is when it's good. It's measured by how good it is when it's bad. And so I think we need to just sort of take the sort of veneer of how you doing? I'm fine away, and sort of recognize that it's okay for us to talk about what our issues are. And resilience, which is a big word right now that people hear, is really about most of the benefit is kind of by labeling and accepting. And then, in my opinion, as a psychologist, the coping process kind of can happen to a great degree on its own.
So you touched on something in your answer, Michael, if you don't mind me steering a little bit down a bit of a different path, which is the concept of diversity, equity, and inclusion. And some of the challenges that racialized and I'm not necessarily sure I'm going to get the term right, non-heteronormative individuals may also feel compounded with the situations that they're feeling relative to their chronic disease and their mental wellness. Can you comment a little bit about the experiences of those populations in terms of your practice, where you may take a bit of a different approach because the experience might be different?
Yeah, no, I love that question. And I guess the best way that I could answer it is really from an experiential perspective. So, I'm a psychologist, so people get referred to me when they have problems, so to speak. We're kind of caregivers, so we're there to help people who need help. But as a psychologist, what's fascinating to me is that when you actually understand a person's experience, I can't tell you how striking it is where you're sitting there with somebody and you think to yourself, if I was in your situation, I'd be experiencing exactly what you're feeling. This is not you. So we have this sort of silent assumption that we attribute it to the individual. What have you done that has led to this problem? Or what are you not doing that hasn't led to the solution to the problem? When you actually start to listen and understand a person's lived experience, it's amazing how what happens is that it's really about understanding the constraints on the individual and then looking for strategies to try to empower the individual to move forward. And that would be true of really the continuum. So I really do believe that, and that's why I raised that issue, that chronic disease needs to be really seen as an opportunity to really support what are the, and also the second point to it is, illness is not a personal responsibility. We all have responsibility for our behaviors. We all have the freedom to choose, but what we call the social determinants of health are absolutely essential. And I think, people like Tiffany and I are health psychologists, we try to sort of live in that space between acknowledging and working with the social determinants, and within that context, providing people with the opportunity to find a personal pathway to their best. I don't know if you want to comment on that, Tiffany.
Yeah, I was going to ask Tiffany, so maybe social determinants of health is a term that I'm very familiar with, but many people on our call may not be familiar with that. So if you can maybe highlight in your comments, sort of what are those kinds of things that also sort of encroach on us from a societal perspective that play into this conversation?
Yeah, absolutely. So like, as was already mentioned, some of the experiences of individuals that come from minority groups in particular, socioeconomic status, where you might live in the country, whether you're rural or urban, and your access to medical centers, and all of these things are very powerful influences on, our ability to access care and the type of care that we might be able to receive, and what our relationship is with providers and with the healthcare system has very much been influenced by all those different social and economic factors that are embedded in society that we don't have a lot of. Again, coming back to Michael's point of when we speak from an experiential perspective, sitting down with my clientele and hearing about these experiences in that room and us working together, we can't do a lot with those factors or do a lot with making change towards those. So they're there, and we acknowledge them, and we talk about the importance of them and the constraints, like Michael said, that they do place, and then still try to find a way forward with, again, that person's own individual path, and based on what are their values, what are their personal goals, and how do they want to proceed. So those are a lot of the things that will show up. So
it's a lot of navigating, which leads me to my next question, because things can be challenging in navigating the system. And so if we can move to the next question, we can maybe, and it's really about discussing. And how do you suggest even opening the door to the conversations about the emotional impacts of the disease with healthcare providers that are clinical and medical in nature? You're clinical as well, but medical in nature. So you talked about resources before, Michael, that are limited resources. So you see in the commentary here that some people feel like they're being dismissed, and that their physician doesn't see beyond sometimes that textbook diagnosis. We know that's not true, but sometimes perception is 9/10 of reality, and it can feel very much that way. So how is that culture shift being managed? And have you seen over the life of your practice a change in that conversation, in the way that the medical folks that you work with chat with people?
Yeah, it is a great question, and in fact, I think it's really, I find it interesting to take a sort of a temporal perspective on it and compare it over time. So I've been in practice about 37, 38 years, so I've seen a kind of the opportunity for time. And I think there really is a culture shift happening. And so I can just look to medical schools, how physicians are being trained. I look to professional programs that are trained. So for instance, at my university, which is very common around the country, all of the sort of health students get pulled together. The very first week that a medical student's in school, they actually meet with someone with chronic disease, multiple chronic diseases. And their task is to understand the person and try to tell that person's story back to them so that they feel that they've been understood. And similarly, I think there's been a shift in how we actually screen for candidates. So lived experience, diversity is really part of the screening criteria. The challenge, I'd like to just sort of elaborate a little bit, if I may, on it, because it is challenging. And I just like to help the audience sort of understand why they may feel this. Why you can see it in the second sentence. People on our call say often feel like they're being dismissed and that their physician doesn't see beyond a textbook diagnosis. So this is actually a common experience. And I'd just like to kind of sort of tell a little story so the audience kind of understands where that comes from. And the purpose of telling the story is because I'd like to empower you to address it. Because one of the things that we know about the clinical exchange is that physicians are trained to deal with, we see it on the page, the diagnosis. But you may be the one telling the physician what that is. And if the physician knows it, they can't unknow it. They may not pull it out. And so the challenge that physicians experience is really based on what we call the scientific method. So in our country, physicians are licensed, they're certified, and they practice what's called evidence-based medicine. So they have to, drugs have to be evaluated, procedures have to be validated, and this is all based on Sir Isaac Newton. Sir Isaac Newton's view, we actually call it the clockwork model of medicine. Sir Isaac Newton's view was that the body's like a clock. If something is wrong, you can take it apart, find the offending piece, replace it, put it back together, everything will work perfectly fine. This is a model that's sort of shown itself in how professionals operate, which is diagnosis. They start, what is the diagnosis? And so we call it reductionism. They kind of get it down to a diagnosis, and determinism. Once they know the diagnosis, they now know the treatment, so they just tell you what to do it, and you do it, and it's better. This is where this sort of shift kind of happens, because in the context of that sort of what we call simple model, we now understand chronic disease to be complex. And what I mean by that is just imagine that you're about to serve a great big serving bowl of spaghetti, a huge serving bowl of spaghetti. When I say complex, what I mean is every one of those spaghetti pieces is a pathway to change. So the doctors kind of feel like they're going to get it down to one thing. And we know that the disease is so complex. And so this is where we believe the relationship kind of comes in. And so this may sound odd to the audience, but maybe you need to support your doctor in becoming open to understanding, because we know that doctors are aware of this. But what ends up happening, because of their expertise, if I don't know what to do, I won't do anything. But many people living with chronic disease don't want to be told what to do. They just want someone who can listen to them, support them, and what we call engage in shared decision-making. Now, when you talk about understanding, support, shared decision-making, I've yet to meet a physician who doesn't agree with those things. So I think it's an interesting sort of dynamic. I worry a little bit because it's almost kind of like, it's like right now, imagine, somebody who's pro-vaccine kind of encounters somebody who's pro, anti-vax, and one person tells the other person what they should do. That doesn't go very well. I think what we really need is to understand where the different perspectives are coming from. And so, most physicians are very aware of this chronic disease model, and the culture shift is really about, and I guess I'll end my comment with the following. Doctors will tell you they don't have the time to do this work. And what we respond to is, it's not finding the time that you think you need, it's using the time that you have. And so there's a little hint there. Doctor, I know you're busy. I know we've only got about 2 or 3 minutes more left, but can we really talk about this situation? We don't have to finish it, but can we actually start? Because I'd really like to have some help from you as how I can navigate this in the context of some of those social determinant issues that Tiffany talked about. Presented that way, most docs are happy to provide that support. So I think there's a potential for a collaboration there. Now you know why I said that I really think that sort of getting patients to be active in their care is a very important way forward.
So, and those are wonderful sort of analogies. The spaghetti bowl I will never forget now with respect to my own health and my own care, because it is complex, which again leads to my next question for you, Tiffany, is there's one thing between the relationship that people have with their physician. There's a totally different relationship that you have with your own family members. So how do you deal with the family members who doesn't understand that burden of a chronic illness? how do you make them understand the strands of spaghetti in the bowl?
Yeah, that's the excellent question, and such a difficult and challenging experience for folks living with chronic diseases and navigating that within the context of their own family relationships that are going to be complicated by everything else that goes along in those close family relationships that show up from day to day. And I think that, you know, a piece of it is, you know, trying to, I guess, you know, find for yourself or decide for yourself and think about how much is this person going to be able to understand about, you know, what this burden is of living with this disease when they themselves are not living with it. How much can I expect them to truly understand, and what's their capacity going to be for that, to be able to, you know, what level, or what's my expectation for that. And I think that, you know, when we were talking earlier about the disease-based distress, and one of those pieces being the difficulties that show up in close relationships and with family members and whatnot, that there's strain in those relationships when people aren't feeling supported, you know, the way that they want to be supported, or they feel like their efforts are being thwarted by actions of other people in the home, and the experiences of kind of coping with that, and how challenging that can be. And I think that, you know, Michael and I were chatting earlier about some of the difficulties that show up when we think about how we try to support people in our lives, and that one of the things we do is, you know, in our best intentions, we're trying to come from a helpful place, and I think that that's a lot of what shows up in these relationships, is that the support that's being given is coming from a place of valuing that I want to help you and I want to care for you, and to do that in a way that's helpful, but I'm probably coming at it from my own lens, from my angle, that I might be doing what I would think is helpful in this situation, but not necessarily what you think would be helpful. And as we were chatting about this, I had thought of this example of when my spouse was starting out a new home business, and he was really, really stressed about it. And I went into the home office, and I saw that the office was in chaos and it was really disorganized. And I thought, oh, this would be so helpful in getting him organized. And I went to Staples and bought all the things to try to help get the office set up and got it all tidied up. And then I was on the phone with my mom later, and I was telling her about how helpful I thought I was being. And she said, yes, that sounds like it would have been very helpful for you, recognizing how important organization is for me. And that's not necessarily what my spouse needed in that moment, but immediately I kind of am acting out of this frame of mind of what this is what I think is helpful. So, you know, being able to have conversations about, you know, in supporting me, you know, could you ask in that moment, what is it that you need, and try to have really clear communication about the type of support that you're looking for. And like, you know, Michael mentioned earlier, a lot of it is about, you know, listening and just being heard and being understood, and not necessarily about problem solving or being told what to do. So trying to be able to kind of find that common ground, and having that discussion around opening up, you know, what can support look like in our relationship, and how can we kind of be creative with that.
So great example of sort of that self recognition, or somebody else recognizing for you what is beneficial to you. So yeah. I have lots of stories I could share about that for sure. But one of the things in my next question focuses on the concept of loss. And so many people in their health journey, and Michael, you talked about it, sort of at 50, you have one diagnosis and one medication, and so on and so forth every decade. Those are still really productive years for people. And there are some individuals that have the experience of having their work life stunted as a result of their condition. And so many of us identify around our work and what that means, and what brings meaning and joy to our lives. So how do you deal with that kind of a loss, that something that you might not necessarily even think would be one until it actually is right there staring you in the face?
Absolutely. Yeah, this is a really, I think, important question. And for me, this is one of the biggest indicators of where we would sort of differentiate sort of disease-based distress from sort of mental health distress. And the way I like to understand it, and this is psychology 101. This is how the human brain works, just to put it in context. The perception of threat leads to the feeling of anxiety. The perception of loss leads to the feeling of sadness. The perception of unfairness leads to the feeling of anger. So I'm trying to say here that anxiety, depression, and anger are normal, healthy feelings. The degree of the loss, the degree of the threat, the degree of the unfairness will predict the degree of the distress. And so that would be sort of comment number one, which is just really, so to ask, if someone's really struggling, then it would be like, well, what have you lost? How much has this? And you're absolutely right. Many people, especially in our kind of contemporary society. So, you know, we all have these phones, we're all on computers, you can work 24/7, you can socialize, you know, so merging of work. Many people, when their work ends, they lose actually a lot of social relationships as well. And so really just examining that. And the very first thing is to really sort of be kind of clear with yourself on what is it that you've lost. Because unless you develop a mental health disorder, and the way to think about that is that, you know, you're so depressed that you can't get out of it on your own. You're so anxious that you can't break through it on your own. And that applies to, you know, between 6 and 12% of the Canadian population for anxiety or depression, which means 94 to 87% of us are doing just fine. Hang on. So these are individuals that once we understand the loss, we can start to adapt to it. My second point, and it's sort of it's simple but really complex, but in fact it's been true for as long as we've known, which is the strongest predictor of happiness is flexibility. And so as we get through life and notice that life has a kind of a journey in which burdens accumulate, it's not like you can have 5 stresses in your life and when the 6th one comes along, the first one disappears. So now you only have 5. We carry our burdens through our lives. That as we have to be really prepared to recreate ourselves. So we used to think about stages of development, and we don't talk really so much about stages of development because it's kind of like, you know, when I started my career, most of us sort of spent our career in one kind of job, and we sort of did that. Now people that are kind of entering workforce are told you're probably going to have 17 jobs over the next 30 years, right? Because you'll have to reinvent yourself every few years as things kinds of change. And so it's that concept of flexibility. So there's a certain amount of grief allowed here. So when you have a loss, and it may be a very personal loss. So for instance, do never underestimate the grief associated with the loss of a pet. Maybe I should say that again. Never underestimate the degree of grief associated with the loss of a pet. If you're a pet owner and you lose a pet, it's a tremendous loss. And so I'm just trying to say that we don't judge the degree of loss. I lost more than you, so I deserve my feelings. You don't deserve your feelings because you only worked part-time. We don't do any of that judgment at all. We simply ask you to reflect on yourself and say, is it a little, a moderate, a lot? And sort of fully process that loss, because then that allows you then to, if you adopt that, okay, now I need to take this into consideration. And, you know, 2 comments here. One is, remember when we went through the downsizing about 15, 20 years ago in the workforce? We sort of, and many people in the audience will recognize it's like people were just cut left, right, and center. For instance, every psychology department in Ontario was cut in 1992. It was only the main teaching hospitals in downtown Toronto that kept psychology departments. The system in Ontario decided that they didn't need them. So psychologists were terrorized. This was the worst thing that could possibly happen. 2 years later, most of those people were super happy they lost their jobs, because that forced them to sort of recreate themselves, and they really liked what they got. And the second point here is that most people who have won multi-million dollars regret having won it 5 years later. And so it's not having what you want, it's wanting what you have. And so I would say that if we could really kind of start with that acceptance piece, and then give ourselves the permission to understand what our losses are, and really to grieve those losses, then what we'll find is that, and we psychologists call it sort of it's a transformative experience that is genuine emotions when they're experienced. You don't have to do anything to change them. The experience of the emotion does the changing, and that's what we know about grief. You only see psychological damage associated with interrupted grief, not with experienced grief.
It's a very fulsome and complex kind of answer to something that is a very challenging thing for individuals to navigate, which is why the question of coping. So oftentimes people will reach out to many different places to have that. And our next question really is focusing on, how do I deal with all of the different and oftentimes contradictory inputs that I get about navigating this emotional distress that I'm feeling in the experience that I'm having of managing my disease, managing the things that all surround that make me a whole human. So Tiffany, how do people truly evaluate the options that are on the table for them? It's a really wonderful question that maybe doesn't have such a straightforward answer. I don't know, or maybe it does.
Yeah, I don't think it does. I don't think it has a very straightforward answer. Just to kind of come back to, what your comment on, all of these different sorts of messages that we receive about how we should be feeling and how we should be responding to our experiences, and to link back into what Michael was saying, that there is something really powerful about being, having something like grief and loss be acknowledged within the context of chronic disease and how that might impact your identity or impact your ability to be able to work. And when people are given permission to be able to feel what they truly feel, that there's this sort of like, aha, like I understand what, grief and loss is, and it's, more normalized, although still sometimes not within the context of bereavement, like a loss of a loved one, but not with these other losses. We're sort of socialized to, not kind of have that strength of experience or that sort of emotional response. And so I really think that there's so much power in being able to accept and acknowledge that this is how I'm feeling, that this makes sense given the circumstances, and to be able to go through that process and to really, like Michael said, to be able to kind of start to finish and have that be the case. I think that too, with like lots of contradictory information and needing to evaluate options, and kind of the confusion that's out there, particularly when people have chronic conditions or multiple chronic conditions, and they might have lots of cooks in the kitchen, talking about the situation from different angles. And sometimes the information is coming out as seemingly contradictory, like one specialist told me this, and now I'm confused, and I don't think it quite sounds like what this other person said, but I'm not sure. And I think that being able to clarify those things comes back to another sort of running theme of what we've been describing as becoming empowered as an individual in your healthcare provider relationships and in the system, to find ways to be able to table that and bring that online. Like, this person, this specialist recommended this, I'm confused, how does that fit with what you're saying? And to be able to feel like it's okay to ask those questions, and not just okay, but vital, because if you're walking away confused and you don't know which way to go, left or right, then this is really important information for you to be able to continue to manage. So again, I think it comes down to finding ways to get empowered and to be talking about these things, and recognizing how common it is for people to feel confused when they're juggling so many different, maybe medical and mental health chronic conditions at the same time.
So
if I could
go ahead, please do. Yes, absolutely.
Yeah, sorry, if you don't mind, I just want to make a comment there, because I think it's such an important issue. And there's really two things I'd like to say. One is, if you're living with a chronic condition, you will become an expert in yourself. And when we think about what it's like to live with a chronic condition, I've had this experience mostly in my work in inflammatory bowel disease and gastroenterology services over the years, because can be very difficult to diagnose GI conditions, and they're just kind of complicated. And the question is, when the person living with the condition kind of says, "No, my pain is different. This isn't my normal pain." And then the doctor's saying, "No, it's probably just this, it's probably that." And one of the things that I just tell the story, just hoping that it's a bit helpful. And that is because I've been through this so many times, right? Because I started working in gastroenterology at the hospital here in Halifax in '88. And almost every single patient, they know their pain. So the end of these stories that we've seen time and time again is where the person is saying, there's something different here. And the doc says, oh, it's probably just this. And at the end of the day, we find that there is something different. So this is a message that I think is actually really important for people to kind of anchor in your own experience. And then if you can say, it's sort of like, this is a different experience to me. So this kind of taps into a person's ability. The second thing I'd like to say about this is really important, because this is a big bugaboo for me, because I work in the health field of health behavior change, obesity, diabetes, cardiovascular disease. And everyone's saying, like, what do I do? What do I do? Like, should you be on the ketogenic diet? No. Maybe it's intermittent fasting. Oh, you need to do mindfulness meditation. Like, we're just bombarded with, like, you should be doing this, you should be doing that. And so I just want to sort of kind of address this. People are confused about what their options are. What should you be doing? And so I just like to sort of give you an evidence-based response to sustained behavior change. So the people that are actually, okay, I've got to change my relationship to food. I've got to incorporate physical activity into my life. I really do need to figure out how I can sort of continue to take these medications as prescribed. And so when we have all these options, how do I change my behavior? Here's the pathway to success. Step number one, are you interested in doing it? And if you're thinking, then don't do it. Step number two, when you do it, are you glad you did? And if you do it and you think, well, it was all right, don't do it again. Step number three, do you want to do it again? In other words, what I'm trying to say here really is the pathway to success will pick you as much as you picking it. And we often see that right now. What should I be doing? Oh, Dr. Shepherd, should I be doing CBT? I heard about this, should I be doing that? Turns out at the end of the day, the pathway to success for the person is when they're going to say, I'm actually interested in doing that. I'm glad I did it and I want to do it again. And so there is a certain extent to which I'm trying to encourage us to pay attention to what we psychologists call it the wise mind. And you know what this is. That's that gut feeling when you think something's wrong here, and then you sort of talk yourself out of it. How many times at the end of the day have you said, something was wrong, right? It is too good to be true. And so I think it's a really great kind of complex question around navigating that sort of potential contradictions.
Speaking of gut, that's really the sort of the central, we have a combo question next, which is entrusting your gut. And is that one of the signs, or what are some of the signs of people with chronic health conditions might be experiencing mental health challenges related to their primary disease? Is it a gut thing? Has COVID, I can't go through a session without asking the COVID question, which has been such a curveball for so many people for the last 18 months. And if it is really accelerating people's gut reactions or interfering maybe with natural gut reactions that people might have about their distress. So Tiffany, what would you say about that?
Yeah, I think that, with respect to the mental health challenges associated with the disease, we hear a lot of, I'm feeling like I'm failing at my disease. I'm feeling really overwhelmed. I'm feeling really burnt out. I'm feeling really frustrated and confused. And that's kind of language that is really more suggestive of, like, I'm getting to a point that this is weighing on me psychologically, mentally, and emotionally. And maybe I'm going to be reaching out for help at that point, that sort of really heavy emotional burden is becoming, like, using powerful language like that. Like, I'm burnt out. Like, this is really becoming too difficult, too cumbersome, and I don't know what else to do. I feel like I've tried everything. In terms of COVID accelerating, or the impact that COVID has had, the impact of COVID on mental health is, that's getting well established, and pieces of literature research is being pumped out like crazy examining it. And I think that for, with respect to relevance for people who have chronic conditions and how COVID has impacted their daily life and whether or not they might be limiting their exposure, therefore staying home more, that there's some pieces to the COVID experience that seem to be, more linked to feeling more distress, and those being things like loneliness and self-isolation, fear of contracting COVID, financial concerns as well, not being able to work and those kinds of things. So, I do think that absolutely it's played a role in terms of, the experience that they've had and well, that many of us are experiencing, but I think that folks with chronic conditions who probably are staying home more if they are concerned about their exposure risk and whatnot, that isolation and loneliness piece could really be a factor that's impacting them quite a bit.
So
I can elaborate a bit on that as well. I mean, just to be very kind of contemporary about it, today in the CBC News, you will read that if you live in Alberta, your discretionary surgery has been canceled. So if you were being due to have your knee replaced, no, it's not going to happen. If you were scheduled for another procedure that might make a difference in your life, you have a hernia that is really interfering, well, guess what? I'm sorry, it's been canceled because of COVID. And so we see these sort of waves of COVID, and the system was really impacted with admissions and emergencies and respirators. But then we have the sort of shifting away from continuing care. I was talking to rheumatology colleagues not so long ago who estimate that there are 18 to 24 months behind, and that it will take them this length of time to catch up from that. Every 6 months you see, oh, now it's going to be more like 12 or 18 months. So we actually believe that, in fact, the disease impact, and so just to help normalize that for people. And so if you were looking for a procedure that's now 6 months later, who isn't going to be distressed by that? And so there's a number of people, Canadian Psychological Association, for instance, the Canadian Psychiatric Association, for instance, who are really taking the stance that we need to predict that we need mental health resource support, because there's going to be kind of a wave and mental health impacts always follow the sort of physical health impacts, if you know what I mean by that. It's like you get a hurricane, well, you have to clean up before you start to realize what the consequences are. So we do know that mental health impact is delayed. So hopefully we can take advantage of that knowledge to organize services. And again, this is where many people have been taking advantage of telehealth, and hopefully telehealth will provide us some ability to manage that sort of acceleration from COVID.
that segues beautifully into my next question, which is a little bit of a political question. We know that people with disabilities often have challenges accessing health and all of that, what that means in terms of disability. The spectrum is wide in that term. And we know the case in point here with the AODA legislation in this province, and sort of the iterations of it really haven't manifested in a way that they were expected to when this legislation was tabled several years ago. It's a model for other provinces, but the challenge is very, very real for individuals with disabilities and chronic conditions. And so is there something, or is there a way, and maybe even the context of what you were just speaking about, Michael, with respect to the burden from the impacts of COVID long-term and the delays of other things relative to other conditions? Is there something in terms of legislation that could impact the kinds of decisions and access issues that might reduce some of the burdens associated with all of the things that go along around accessing care?
Yeah, this is, as you sort of identify, a huge issue. But I'd like to respond by sort of not maybe answering it, but sort of trying to sort of draw connections. And so Tiffany and I have talked a lot about the sort of people blaming themselves, I'm just not coping well, it's like and we see that every single day, right? Tiffany, the person say, you mean I'm not like this? You've heard this before? There's not something wrong with me? It's not just me that's struggling? You mean other people have this sort of struggle? When we run groups for people living with chronic disease, they love the groups because they say, like, I feel like it's sort of like I'm kind of normal. And so there's a tendency with chronic diseases for people to make a personal response. And then that puts the burden on them. We know about the social determinants of health. And notice that Tiffany said she's working with her patients. They have to acknowledge those social determinants, but Tiffany can't do anything about food insecurity. Tiffany can't do anything about child poverty. And so she has to work with those. So the kind of coming back together, the legislative piece will actually be necessary to create the way we build our cities, the way we build our roads, the way that we allow people to advertise food, the way that we. I really do think that we're starting to understand that part of that spaghetti bowl complexity is that policymakers, city planners, legislatures can't take a distance from health and just simply sit over there and just kind of say, poor you, you're in the health system. Because in fact, health is not just managed by the health systems. It has to be managed. And the reason I'm kind of saying this is because, we need the voice of the individuals living with chronic conditions to not feel that they're just weak, which is why we started by trying to dispel the diagnosis of depression and anxiety. If you qualify, fine, I'm glad you're being diagnosed. But I have to tell you, in Canada, the most commonly overdiagnosed condition is depression. And so we have to be cautious to separate out, this is disease-based distress from depression. And if we can normalize that, then I think one of the next steps is to start to use the voice that we have to actually begin to address that. And it's kind of like we think about Greta Thunberg and that role that she played in the environment. We know that younger people coming into the political system are much more sensitive to the climate. And I just see that the mental health and as with equity types of issues really do need to be provided. But I would like to say that absolutely, I think if we tried to address the burden of chronic diseases only using the medical health system, we could never do it, because we need to get some legislative measures involved as well.
Thanks for that perspective. It's not always an easy conversation to have. We are a publicly funded system, so there is an onus that is there on the system to be able to support the individual. So we have 6 minutes left, and we have 3 questions, and we're not going to get through all 3 questions. They're all wonderful questions, but one of the things we have yet to touch on, Tiffany, and I'd like to start with you, is not the patient themselves, but often the caregiver who sits alongside of that patient, and the burden relative to the caregiver and the stressors related to that. What advice do you have for people who are living with that role for individuals with chronic health conditions, but you're caring for that individual? It's a really sometimes cumbersome role to play.
Oh yeah, absolutely. And I think that speaks to, again, another one of these sort of thematic things that are coming up in our discussion, is that this is not an individual issue, that this is not something that the chronic disease is only a burden to the person who's living with it, or something that person that's living with it is stressed by and needs to manage, but it permeates all spheres, right up to, like we were discussing, just a moment ago, the big picture, big ticket legislative items and that kind of thing. So, I also think, just coming back to some of the conversations or the conversation earlier about, what happens in those relationships, and how do we open up and communicate about what each other needs. And I think that for, both the caregiver and the person that's living with the chronic health condition, and at this point in time too, that could be vice versa, and maybe both are caregivers and both are living with the chronic condition as well, given how common chronic conditions are, that this is, very much a shared experience, and how can we support one another and have conversations about, how can I help you? How can you help me? How can I help you help me? Those kinds of things, and really be open about that. And certainly there are wonderful resources out there that some folks may be able to access, in terms of, caregiver specific support groups and that kind of thing, where you can go and you can have these discussions with people who are in similar circumstances, which is so, powerful in terms of being able to normalize and to be able to share, experiences and share sometimes ideas, but also just to be able to kind of, have other people there in your space and bear witness to what it is that you're going through, and have that support. But yes, again, I think it comes back to sort of being able to talk about, within the context of the relationship, what is it that we're both, dealing with, or that we're all dealing with within our close family of caregivers, and how can we best support each other? How can we, and again, coming back to flexibility, how can we adapt? How can we be flexible? And what, what steps can we take to be there for each other?
Great. So Michael, the last word goes to you, and I'm going to ask if we can skip to question 11, because I think this is a really great summation. We've talked about sort of coping, carrying, those kinds of issues. But what about lifting your own spirit? What are some of the things when we're dealing with all of these heavy burdens? Sometimes, and we enter into these group conversations where we're sharing all of these very, very heavy stories. But in the quiet of the moment, when you have a chance to reflect and really think about it, Michael, what is it that people can do to work to lift their spirits? Because that's part of the normalization process, I think.
For sure.
As well.
Yeah. So I would say that we are designed to handle all of the problems that happen in our village. We are totally unprepared to handle all of the problems that are happening on the planet. And yet we live in a world in which we're having the whole planet's problems promoted to us on Facebook, on the news, on our phones, in our alerts. And so I think the one thing that I would want to say is, first, we have to disconnect. Make your world small. Make your world small enough that it's actually your real world, not the Facebook world, not the, like, we have to somehow kind of let ourselves realize what is our sphere of influence. Second is, what can you control and what can you not control, right? So there's an expression I sometimes use, not my monkeys, not my circus. And so it's like, okay, because I can deal with what I can control. So if you try to focus on what you control, then we talk about managing. And so, you know, interestingly, if you want the quickest win to boost your mood, random act of kindness. It's fascinating psychologically. You want to feel good about yourself? Do something nice for somebody else. All of a sudden, you'll just see that there's a real shift there. And then I'll finish it off by really, really effective coping strategies. Physical calming, ways of achieving a calm, quiet, peaceful, reflective moments. Physical discharge, burning off your stress, finding ways of getting it out. Emotional expression, don't keep your feelings bottled up, express them. Social connection, we're social animals. When we're stressed, we do well bonding together. And then acceptance, that sort of ability to let our experience just be in a non-judgmental, reflective acceptance way. Those are a number of very specific, and now I'll come back to the end. What are you interested in? When you try it, do you like it? And do you want to do it again? And from that list, Tiffany and I spend a lot of our time just sort of exploring with people which of all those strategies will actually pick them to be those effective strategies. So I hope that helps.
This has been a wonderful conversation. I have learned so much today from the two of you. I know our audience has learned so much. So Dr. Vallis and Dr. Shepherd, thank you so much for your time. Much appreciated. I'm sure we'll be in touch again to learn a little bit more as we come out of COVID and other things that we continue to work through. So I want to thank you on behalf of all of our viewers today. I also want to thank our friends at the Diabetes Canada for introducing us to the two of you. It's always great when we can extend our relationships by our partnerships, and also considerable thanks to the running room today who made this session possible. Join us again on Health Hour Live. You'll get a webinar in your inbox soon, so you can go back and touch on all of the highlights and all the great tips and interesting information we shared today. Thanks again for joining us. I'm Leslie McGill from Medical Alert. Thank you for joining us for Health Hour Live. Take care, everybody.